So welcome to this series called the Perioperative Coach. In this series we have top tips on all aspects of perioperative care from some of the world's experts working together to enhance surgical recovery. Don't forget to look on the show notes on topmedtalk.com for additional links to papers, etc. And of course, if you haven't done it already, subscribe to Top Med Talk. Top Med Talk.
Hi there, I'm Joff, Lacey, and I'm now here in the exhibition hall of the annual Congress of Enhanced Recovery and Perioperative Medicine 2018 being held in Fort Lauderdale. So I'm joined here by Mike Scott from Virginia and also from Ross Kerridge from Newcastle in Australia. So first of all, Mike, we're actually next to a poster that you and your team have put together. Can you just tell us a little bit about what it is and why you've done it?
Yeah, well, Ross and I were discussing this poster because he raised at one of the sessions the fact that the knowledge for other providers, apart from physician and anaesthetist and surgeon, of knowing what should be done with the patient is often quite lacking, i.e. the actual awareness of where people are on their pathway. And so we've got a poster here that we've developed across the whole of the Virginia Commonwealth University Health System. And it's basically looking at every individual pathway. So we've given examples here of colorectal surgery, knee surgery, and we divide the pathway into pre-op, surgical and post-op. And every patient goes through pre-op and there's lots of multiple elements of optimization. And then in it, in the surgical pathway, it's got what happens in the pre-surgical unit and then specifically surgical and anaesthetic elements. And in particular, hemodynamic and analgesic strategies to reduce opioids, followed by what happens in the PACU. And then the final part of the page is all about post-operative de-escalation. So really in a single-page framework, we've got exactly what happens to the patient from pre-operative right the way through to hospital discharge for every single specialty.
And why do you think that's so important to have this concept, as you've said in your post, of having everyone on the same page?
Well, even in the PACE clinic, which is our preoperative assessment clinic, it means that the providers there know what type of analgesia that patient's getting for that surgery, so we can give the right materials. We know who's going to get optimised, the type of diets that they're going to be switched to. And then during the actual peri-surgical period, everyone in the PSU and in the OR knows exactly what to expect and what specific elements they need to provide for that type of surgery. Same in the PACU. And on the floor, there's then no questioning of the order set. The nurses can see that the Foley catheter is meant to be removed day one, that early ensures should be started day of surgery or post-operative day one. But at the same time, there's some safety things inherent. So non-steroidal anti-inflammatories we might not start till post-operative day 2, depending on renal function. And there's even red flags for drainage output with bleeding at specific levels of when to contact the attending or not.
The main drive for this is trying to break down some of those barriers that often are challenges to implementing enhanced recovery programs. And Ross, as you mentioned in one of the sessions earlier, it's that allowing everyone to know what is expected. It allows them to be engaged in the process, and that makes a big difference.
Yeah, I think as senior doctors in both Mark and I's case, it's sometimes difficult to comprehend just how much chaos and uncertainty there is in the system. The very junior doctor, the standard ward nurses, the admin staff, all the other staff that work, if they're not really sure of what's going on, sure they can find out, but the advantage of this sort of thing is it makes it very clear to everyone this is what's going to happen. It helps them focus on getting the job done rather than finding out what they have to do next. And all of those things just make the day run smoother and make everyone happy. And it's difficult to show that there's a patient outcome from that. It's difficult to measure it, but I'm sure it makes a huge difference.
I think you've raised an important point, Ross, because it's not when the consultant or attending is with the patient that things go off track. It's 1 o'clock in the morning or 10 p.m. And it's often the intern who's just changed firms. Yeah. So this is why it's useful to have a pathway. But the other thing I think it's important is that the patients, I find, have felt that there's a more professional attitude when everyone's telling them the same message. Yep. As if they come in and they say, well, you might have an epidural or you might have a tap block. They actually really wonder if you know what you're talking about.
Yeah. Yeah, if everyone's changing the story, then you lose confidence.
And I think sometimes as doctors we particularly at the more academic end, we get into great arguments about whether one particular thing is any better than another particular way of doing that. And sometimes it doesn't particularly matter whether you do it one way or the other, as long as you do it consistently. It's like driving on which side of the road.
Yeah.
There's no proof that driving on the left or the right-hand side of the road is better, but if you're in the US, it's a good idea to drive on the same side of the road as everybody else.
Well, actually, over here, Ross, I've learned you, with all the big cars, you just drive in the middle.
Yeah.
And they'll get out of the way. No, but Ross, you also made an important point about outcome measure. As in, it's difficult to measure what this may do sometimes.
Yeah.
And that's one of the challenges, I think, with a lot of the implementation or the components that we're trying to implement, that we don't necessarily at the moment have standardised measures for them, but a lot of them are good ideas, and sometimes you just got to go with it.
Yep. And sometimes, like I've visited a lot of hospitals around the world, and there are some hospitals where you walk in the door and you're greeted and you can feel the calm in the air, and people say, welcome to Fred Blogg's hospital, and this is the way we do it here. And they say it with confidence and strength, and you think, that's a little thing, but gee, that must make a difference to the patient as they walk in the door. And there are others where, we've got lots of different ways of doing things or whatever, but you think, I don't want to come here.
The other interesting thing we found mapping our analgesia to reduce opioids is we know that, I know that whether I put an epidural in, a spinal with some Duromorph or even some morphine, I can get that patient walking the next day. But what's important is the consistency of delivery and restoring function and making what you do work. That's the key thing.
Yeah. Thanks very much, guys. I'll let you finish your coffee now, but I really appreciate that. Cheers.
Top Med Talk.
Nick Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.